Today's webinar is part of our Clinical Judgment webinar series titled Instructional Techniques for Teaching Clinical Judgment, presented by Jeffrey Anderson. I'm going to pass it over now to our presenter. Jeff, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you for having me. Thank you for everybody that showed up today. I hope we can get something out of this together. One of the first things I wanted to talk about before we get into the material is that this is going to be very me and my program centric. That's just because that's all the information I have at the moment about what we're doing and what we're trying to do. And so if you guys are doing things that are better than what we're doing or a little bit different, I'd love to hear about it because I think we can all get better together in this area. And so it's exciting to be part of what's happening now because of that. We can all help each other out. I created a Google group years ago for paramedic educators, and that was the primary purpose, was so that we could share and help each other. And if any of y'all want to join that group, if you're not a member, my contact information will be at the end of this webinar. So I think when we're focusing on clinical judgment or anything really with EMS education, we need to remember ourselves and to have the students remember that the purpose of what we're doing is not just to pass the test or to graduate or anything else. It's to make sure that we're ready for the job that we're going to do at the end of the program. And I think sometimes we forget how sacred of a responsibility that is to care for other people's lives and other people's families. And so as much as we can, we need to remind the students that the whole reason they're here is to build a body of knowledge that will help them potentially save somebody's life or ease their pain or make things a little bit better. So just to review a couple of key concepts about curriculum and teaching before we move into the specific techniques. Uh, Learning and teaching involve three basic things: encoding, storage, and retrieval. So encoding is getting the information into your long-term memory in a way that you can actually use it. Storage is putting it into the long-term memory and keeping it there. And then retrieval is bringing it out of your long-term memory to solve a problem, treat a patient, do a test, whatever it happens to be, whatever the task in front of you is. So the goal with all of this is to have a body of knowledge in their long-term memory that they can use to solve problems when they retrieve it out. And the more you repeat this process with information, the easier it is to do. Now, the way we use information in general is we receive inputs into our senses from hearing, smell, sight. All of these things are important in clinical judgment and treating patients. We got to use all of our senses, and even like the spidey sense that tingles in the back of our mind that tells us something's not right. We got to pay attention to all that. And when we do pay attention to our sensory inputs, then we can transfer that knowledge to working memory. Our working memory is where we actually solve problems. Working memory is where we're thinking, where the cognition lives. And then to solve problems, we bring information in from our senses, and we also bring information in from our long-term memory. So the more we know, the more information we have in the long-term memory, the better we're able to solve problems and to treat patients. And so I think that's really relevant to clinical judgment, because when you have a student who's approaching a problem for the first time, it's very difficult for them to work their way through it because they're having to learn new things from scratch, and they're having to put things together and make connections, and it's very difficult to do. It's hard. It's that kind of thinking is time consuming, and it's energy consuming. Whereas if the student is confronted with a problem and they've been exposed to a similar problem in the past and they've already got a lot of that worked out, all of that knowledge comes back to them and it's available to them when they're trying to solve a new problem. And so the more information we have in our working memory, or long-term memory, sorry, and the better organized it is and the more functional it is, and we've organized it in ways that it makes sense for the problem, the easier it's going to be for the student to confront the task that's in front of them right now. And so that's kind of just an overview of teaching and learning. The environment in this model has to do with resources and other things that live outside the brain but inside the environment. So one of our tasks is to teach students how to use resources appropriately, so so that they can help themselves and not forget things and make sure they're doing things correctly. And also, we need to make sure they know how to use resources appropriately, because I find that especially newer students, they're far too tied to the skill sheet or the algorithm or the protocol, and they don't know how to use it. The resources, when we get to the end of the program especially, should absolutely be used, but they should be used as an aid. I want to make sure that I've not forgotten a contraindication of this drug, or I want to verify this drug dose for this drug I haven't given in a year, stuff like that. If you're having to flip through the book furiously just to get through the patient encounter, you just don't know enough yet, and we need to remediate you. So, like I said, this is just a basic overview of how we process information. But when it comes to EMS education in general and teaching clinical judgment in particular, I think this is very important. I think the long-term memory is the key, because the way we teach the students and the way that we practice the students and have them retrieve information and the problems that we have them solve once we've taught them correctly, all of that builds a long-term memory. It builds a knowledge base in their long-term memory that they can apply to problems. And it makes sense that it would help us with problems that we've seen before, like your fourth or fifth cardiac arrest should go better than your first. But having organized knowledge also helps you with problems that you haven't seen before. You can recognize patterns and recognize things that are similar. So anyway, I know I preach about this particular model a lot, but I think it's crucial for us to understand it. And the last model I wanted to talk about is the registry clinical judgment model. I love this model. There's lots of different schemas out there for clinical judgment and clinical decision making. Dr. Gary Klein has done a lot of work on this with recognition prime decision making. There's John Boyd's OODA loop. There's Kahneman's work on system one and system two. There's lots of different work around this area, but this particular model is unique to us. It's been customized to us, and I think it works very well in explaining how clinical judgment needs to work. In particular, we're going to talk about the circles in the middle. So as you can see from the model, it covers an entire call, and there's aspects of uh, our job that encompass the entire call, like clinical judgment, leadership, communication. All of these things need to happen throughout the call. But then in the middle, this is where the information processing really comes in. And so, as we're coming up with techniques to teach clinical judgment and to assess clinical judgment, we need to be thinking about which area or areas of this model will be touched on by that particular instructional strategy or assessment that we're trying to do. So it all starts with recognizing cues, and having a lot of knowledge helps us recognize cues. There's that ancient EMS maxim that the eye can't see what the mind doesn't know. So if you've never seen this particular clinical presentation, then it's going to be tougher for you to recognize what you're seeing. So again, you can't get away from just having a very large, organized knowledge base if you're wanting to do clinical judgment effectively. Then the next step is, once you've recognized that a cue exists, that you analyze that cue. So is this an assessment finding? Is this an answer to a history question? Is this a sight, a smell? Whatever it is, whatever sensory information has come into your working memory, this is a model of what's happening in your working memory. So you define a hypothesis next, which means you attach a value to that cue. You've analyzed it. You've determined, let's say you have a patient that you pulled out of a house fire, and you put them on your pulse ox, and then you look down at that reading and the pulse ox says 100%, but you can see they're not breathing very well. Their skin looks horrible and they're unconscious. Well, analyzing the cue, one of the things I want to think about is my pulse ox even correct? Could they have carbon monoxide poisoning, which would give me a false positive reading on my pulse ox? So then I have to decide, do I believe the pulse ox or not? That's my hypothesis. If I don't believe the hypothesis, if I don't believe the pulse ox, if I think that they do have carbon monoxide and we're also dealing with the other stuff, then my solution is going to be to put them on oxygen, possibly even ventilate them. Then I'll do that. And then I'll evaluate once I've done that action, and then I'll revisit it. I think the take action and evaluation are very important, because every action we take generates new information. How the patient responds to the whatever it is we did. And so one of the things we need to be really putting in front of our students over and over again is to reassess and evaluate what they've done so that they can take their next action based on the patient that's in front of them, not the patient that was there a minute ago that we changed by taking an action. And so having situations where the students are faced with a dynamic patient that's changing based on what's happening is very important. And so this again, this model, the circle, whatever it's called, it needs to have a really cool formal name, but I'm not aware of what it is. But you may do this process 20, 30, 40 times on a call or more, depending on how complex the patient is, how long you're with them. But every step of the way, there's specific things that you could do to improve this process. And so as you're planning your curriculum, as you're planning the experiences you're going to put your students through, think about where in this process we could add some complexity, or we could um, maybe more explicitly teach how to do whatever it is you want them to do. So that's an overview of some of the basic tenets that we've covered in the workshops and in the webinars. Thank you for indulging me in that. The first actual instructional technique I wanted to talk about is just a reminder that it really does take a village to raise a paramedic or an advanced EMT. This is not something we should be trying to do on our own. And I realize that for some of us, all we have is us as far as actual staff in our programs. But one of the things I'm hoping we can do, especially in this age of technology, is we can reach out and have other people help us. If we can work with other people on building our resources, building our curriculum, building our assessments, writing scenarios, all of these different things, if we can share these resources with each other, then we can have a much richer curriculum overall. And it's not up to just us to make that happen. Because, I mean, those of you that are working in these one person shops, I don't know how you do it. I've always had a clinical coordinator. And even with me and my clinical coordinator, we still have struggles getting things done. And my program's not nearly where I want it to be yet. And I see where I want to go, but it's hard to get there because there's just so much time. And once you run out of time, you got to move on. So if we can help each other out on things like this, I think it would be great. For instance, the new performance items that the registry is using on the tests now. There's no reason that every one of us should write our own performance items to put in our LMS. We could collaborate on that, and we could write some together and then share them so everybody gets more and more and more. Plus they're going to be higher quality because more hands have touched them, more eyes have looked at them, more brains have processed them. And so think of ways that you can involve other people to help you with things. And then if we're helping each other, then we're all going to benefit. And one other thing I want to remind you about, y'all are not the village idiot. That is my job. That is my position. I've worked hard for it. And so the whole Dunning-Kruger thing about not feeling like you're qualified and not realizing that you're able to do this job, you are. If you're in a position as an EMS educator, you are able and you have the ability and capacity to do this, but we could all use help. And so don't take needing help as a sign of you're not worthy. You absolutely are. And so I think once we get past that, and once we develop networks and we learn to help each other, we're really going to ramp this thing up, and EMS education in general is going to get a whole lot better. I'm very excited about that, if you can't tell. The next technique that I want you to think about, and this is a more of a concept, but it breeds specific techniques, is scaffolding. This is where taking some serious thought to your curriculum becomes very important, because it's not just about what you teach, it's also how you teach it, how you break it down, when you present concepts to your students. And so scaffolding in a nutshell is basically you want to withdraw support over time, uh, and then have the students' performance get better and better. So we're obviously trying to get to where we have entry level competence. The student graduates being able to run the calls on their own, no help. And so we present a well sequenced curriculum across the program to them. And over time, we withdraw support, but then over time, their performance gets better. And so we're switching autonomy from us to them over a course of a planned, sequenced curriculum. And so one of the ways that I've learned over time to kind of conceptualize scaffolding is the concept of I do, we do, you do. This is from the explicit and direct instruction literature, but I think it makes a lot of sense. And so when I'm talking about I do, I'm talking about us. Now, we can have a whole debate about student versus teacher centric and everything. That's for another time. So for now, when I talk about I do, I'm talking about what we do as educators. And then we do will be us and the students together. And then you do is the students on their own. So there's a lot of work on our part to do this. So some things that we do is we think about what needs to be taught, and we also think about how the information is going to be used. I think that's critical. It's not just that we have this list of topics to cover, but how are these things going to actually be used in real life? And this is one of the advantages that we have as allied health educators. We've all done this job. So I know how this is going to work. I know how to treat patients. I have a very clear idea of what they need to know to do the job that I either used to do or I'm still doing. I think we need to be thinking about clinical judgment in every phase of the curriculum. If you assume that clinical judgment is just for scenarios in the lab and the field, I think you're missing out. I think we need to start with clinical judgment from the very beginning. And the reality is, everything we talked about with clinical judgment, it's just about processing information. And so they need to be able to process the information we give them throughout the entire curriculum. So I would start that very early and be explicit about how this works, how to process the information, give them tools to do that right from the very beginning. Don't wait until you start doing scenarios in the lab. Sequencing the material appropriately is very important. If we present things to students ahead of when the prerequisite knowledge has been presented, that leads to a lot of frustration. And so we need to be very clear about where we do things throughout the entire curriculum. The whole thing should be planned out. Even if you have multiple courses like we do at a community college, you can still plan between the courses at the program level to make sure everything is sequenced appropriately so that they're getting the information at the right time and we're trying to hold them accountable for it at the right time, which leads to establishing reasonable but challenging expectations. We always want to be pushing them, but we've got to be careful about how far we push them. If we induce a situation of cognitive overload, they can't learn anymore, and we've kind of halted progression. So we want to push them. We want to make them getting better. We want them to challenge. If they're feeling really comfortable with things, we're probably not pushing them hard enough. School is not a time to feel comfortable, but it is a time to feel safe. So we can challenge them without crossing the line by sequencing things appropriately and then reading the situations that we're in and making sure that we don't push them too far, but we do push them. And then gradually removing support while increasing expectations until we get to entry level competence. Teach the students what you want them to know. I think this is critical. And you may disagree with me on this one. There's a big debate in education about inquiry-based learning versus explicit instruction. And should we create situations where the students figure things out for themselves versus should we just tell them? I got to say, I'm a big believer in telling them exactly what I want them to know. I think there's going to be plenty of times for students to process information and to figure things out. But I want to make sure that the information that I need them to know is taught to them explicitly so that we can move forward. That's just, to me, that's just a better way to do it. We can have arguments about that later, but for right now, it's my show. Also, I think demonstrating how the material should be used is very important. Again, we're all expert paramedics and advanced EMTs. We should show them what that looks like. And so when we teach them something, we should tell them how we would do this, how we would use the information, how we would process it, what we think is important. I'm going to talk in a minute about worked examples. That's a very important part of that. Now, one little side note, I wanted to share this website, but I couldn't figure out the best place to put it. So I put it in the I do part because one of the things about us designing instruction effectively is trying to make it as real as we can and show students the way things work in real life. And this is one of the best tools that I've found for this. Dr. Melick has several YouTube channels where he actually films in the emergency departments he works in. And so you're seeing real patients with real problems, and you're able to get a sense of what these things actually look like. And so one of the things I do when we build curriculum, build material in our learning management system is I'll include relevant videos from Dr. Melick or other places that actually show the types of patients we're talking about. Like in the pediatric respiratory module I just built for our EMT class, I have several videos of children with retractions and with modeling and with increased work of breathing. So instead of me explaining that or me showing them a still image or a drawing, they can see a child that's working hard to breathe, that has retractions, that has mottled skin, and that'll develop a pattern they can use for later. So I think part of the I do part of this when we're developing curriculum and developing content, find resources out there that will bring that living seal of reality to what we're teaching them. We want to make it as real as we can for them because again, it goes back to that whole, well, there's the street way versus the real way or the book way. And I don't want them getting that impression. I want to teach them exactly the way they're going to do it in the street. And so if I can do that in part by showing them real people with the problems we're talking about, so much the better. So I commend this particular channel to you. I think you'll find a lot of good stuff in there. Dr. Melick does an amazing job. So the next step in scaffolding is the we do portion. So in this case, you work on problems together. So if you're teaching dosage calculation, the I do part would be the prep and then teaching them the concepts. The we do part would be working through problems together. Say have a set of 10 or 12 problems that you work through together. You're showing them how you would do it. You're getting them to work on them too. Maybe solve it part of the way and then have them solve it part of the way, and then you do feedback together. This would work well for EKGs. You could do this with classroom scenarios based on PowerPoint, or project your eye simulate up. However you want to do it, there's lots of different ways to create the experience. But the idea here is that we're doing it together. So they've listened to me. I've taught the concept. Now we're using the concept together. And then once we've done that, then we're going to switch to them doing the concept on their own and then coming back and giving them feedback on what they did, whether that's homework or an in-class assignment. Maybe you have them run a scenario on their own in the lab. But just so this whole point is to transfer responsibility from you to the students so that at the end of this, they're able to function on their own. And again, this process is going to take place over the course of the entire curriculum. So every time you teach a new concept, we're kind of starting over. And that's okay because that's how it has to work. We teach a lot of different information that is related but separate. And so we kind of do that all the way through. And then at the end, we put it together. So the next technique I wanted to talk about is worked examples. That goes back to the I do and some to the we do. But the idea is to show the students how the information would be used. So we don't just have this dry set of concepts that we're expecting them to put together on their own. We want to show them how it's going to be used, which again, our particular circumstance makes this really easy because I'm teaching them how to do what I've been doing for 23 years now, or, in your boat, maybe even longer. So I know how this works and I can share that with them. And this is not war stories. This is not for entertainment or self-aggrandizement. This is about, let me make sure you know how these tools that I've just taught you about are used. And so some examples, in-class demonstration, whether it's in the clinical, I mean, in the classroom or the lab. I like running scenarios myself so that the students can see how I would approach a problem. That doesn't mean they have to do it exactly how I did it, but they can give some ideas of how I do it. If we do a PowerPoint scenario, sometimes I'll have them run a scenario and I take it. Sometimes I have them run oral stations that either they wrote or I wrote or one of my partners wrote, and then they'll see how I process through it. So in-class demonstrations, if it's a skill, just show them the skill. If it's interpreting an EKG, I'll interpret some EKGs on the board while they watch. So I can tell them what I look for and why I think certain things are important and certain things aren't. So we talk about classroom scenarios, lab scenarios, video scenarios. This is something that I've started to do recently as we've transitioned to more of a hybrid based program. I will take the PowerPoint case scenarios that I would have done in class and I'll run through them on a video and then post the video. So I'll have a short video that teaches a concept, then I'll have a video with a worked example, and then there'll be some sort of assessment for the students to do. Uh, Zoom scenarios, I have not done this yet, but I'm setting up for this. My goal here is to involve my medical director and other people like other faculty or other paramedics. I want to get 2 or 3 people, and then let's talk about a scenario together. I think the medical director is very important here because medical directors don't always do a great job teaching content from scratch. But what I've always found is physicians are really good at explaining how they think about things. So if you can put a case in front of them and then you and your medical director talk about it, um, one of the best things about this is I'm not tied to a specific class time to do this. I would love to have the medical director come to class and let's have this discussion face to face, but that's not always possible. And so with this, we can agree upon a time. We can get together by Zoom or Teams or whatever, protocol you use, whatever program you use, and run through 2 or 3 of them, record them, post them to your LMS, and then maybe create a quiz or something to assess what the students should have learned from that. I've not done that yet, but we're getting ready to start doing that. I'm pretty excited about that. I think it's going to really bring some benefit. It's almost kind of like a podcast, really, just having some little small podcasts with people. And that's one of the benefits of podcasting to me is you get to hear how people think about things as opposed to just, listening to a lecture. Um, and then scenarios with other paramedics, scenarios with your medical director, scenario with your medical director and other paramedics, your preceptors, program graduates. I love bringing graduates back and having them run students through calls that they've been on and then talking about what they did and or what they didn't do, what they wish they'd done. Those work very well. Because I don't know if you've noticed this or not, but our students look at us like we're their parents, and sometimes it's almost like they're looking for reasons not to listen to us. So if you can bring other people in that they're going to respect more, like their coworkers, that may help you in a way that you can't do yourself. So those are worked examples. Just again, it's nothing more complicated than just showing the students how you would do whatever the task is that you're asking them to do. And I think with clinical judgment, that is crucial. Show them how you do clinical judgment, how you process the information that you get, and how you create your hypothesis, how you apply it. I think that's going to go a long way to teaching them how to do it themselves. And again, we're not saying they have to do it exactly like you. We're just giving them a place to start. Okay, the next thing that I think is kind of fun is to teach about common diagnostic challenges. So, in the world of diagnostic reasoning and clinical judgment, there are common patterns that show up across, all spectrums. And so, finding some of those patterns, finding some of those problems, and then incorporating them into the experiences you give the students will help them build patterns in their long-term memory so that they can go back and solve problems. It's not just the patterns they build doing scenarios in the lab that matter. The stuff they do in class will help, oral stations, any kind of interaction you have with the material helps them build patterns they can remember for later. And that's one of the goals that we have is having a big set of patterns in their long-term memory that they can apply to the problems that come in front of us. And so, one of the things to remember is we don't want to just teach the classic presentation of whatever disease we're talking about, like an acute coronary syndrome where they have chest pain that radiates to the left side and it feels like an elephant standing on their chest. Yeah, we do have some people that present that way, but that's not always the way it presents. So we need to come up with some of these other atypical presentations too. One of my personal heroes is a guy named Dr. Amal Mattu. He's an emergency medicine educator and physician. He's an excellent teacher. He's really good at EKGs. So if you want to learn more about EKGs, anything Amal Mattu has to say is going to be gold. But he commonly says in his talks that classic presentation is Latin for 15% of the time. And another way to look at this is the patients don't read the textbooks. So if the only times our students are exposed to a particular problem is when we give them the textbook presentation or the classic presentation, we're not really training them to use clinical judgment. We're not training them to solve problems. We're just having them repeat things over and over and over. And so obviously it's good to start with the classic presentation. That would be a great way to scaffold this, is to start with how it normally presents, or the common way, but then takes them places where it's not so common and build them up to that. So some examples that I've found, and there's tons of these. Tachyxiety is one of my favorite ones. I ran across a journal article years ago that talked about SVT being a common cause of anxiety, or really what it was is SVT was misdiagnosed as anxiety, because a patient would go to their doctor and they would describe them having episodes of SVT. And if you listen to people that have SVT describe it, it sounds a lot like an anxiety attack. And so you have all these people are getting diagnosed with anxiety and getting put on medication for anxiety, when really what happened was they were having paroxysmal SVT. And so we created some scenarios in our class where it sounds like it sounds like anxiety to begin with, but if they take the time to do a proper assessment and they check the vital signs, they'll find out that the heart rate is very fast, which should prompt them to put them on an EKG, which will prompt them to recognize the SVT. So it's a known published scenario that we've incorporated into our program, just so they'll remember that pattern, so they won't blow off things like anxiety, because it's very easy to blow off things like anxiety and headache and stuff like that. And so we're trying to present them with situations where that's not a good idea. You need to do a proper assessment every time. The point is not to get them or to like trick them or anything. This is a known thing. Another one that I came across is I was listening to a lecture about clinical decision making, and they were talking about how in their particular area of the world, there's a whole lot of kidney stones. But one of the problems with kidney stones is patients with kidney stones, the way they present is very similar to the way that a patient with an abdominal aortic aneurysm could present. And so if you're not careful, you key in on that kidney stone diagnosis too quickly, and then you miss the signs of something else. So we've written a scenario that does that, just to see. I wrote this one in particular for my medical director to take the students through. Again, the goal is not to trick them; it's just to see them process through. Will they do a real assessment? Will they be thorough? Will they not fall victim to confirmation bias too quickly? And it's a fun little scenario, but that didn't come from me. That came from another talk by somebody else. Uh, Seizure, syncope, and sudden death, I think, is a really important concept people need to understand. Your dispatch information and what your family members and other people say when they say somebody's had a seizure or they've passed out can sometimes be actually sudden cardiac arrest. And so teaching your students to have these three things connected so that they're looking for all three of those things in any circumstance that could possibly be any of them, I think is important. It's very common for somebody to have syncope, and then it's described as a seizure because when they passed out and their brain started to hypoperfuse for a bit, they shook. But if they only shook for a couple of seconds and then they woke up pretty quickly, probably wasn't a seizure. And the worst case scenario is somebody says somebody had a seizure, but what it really was is they're in sudden cardiac arrest. And you can find videos of that on YouTube where athletes drop suddenly and everybody's standing around them trying to figure out what to do until somebody finally realizes 4 minutes in, hey, they ain't got a pulse. And so creating experiences where the students are confronted with those diagnostic challenges and helping them work through them and develop them that pattern is very important, because what we want them to do is if there's any chance it could be sudden cardiac arrest, that's where they go first. And they rule that out ahead of time at the beginning before they work on all this other stuff. Another one that I thought was fun was angioedema. I know I've talked about this on another webinar where, angioedema is not always just anaphylaxis. So we have some scenarios where there's ACE inhibitor-induced angioedema, there's hereditary angioedema, something we have in our area. And so just making sure the students don't just assume that if a swollen tongue is there, it has to be an allergic reaction or nothing else. There's other things that cause that too. So again, building patterns that will help them later on. It's kind of funny. It wasn't 2 weeks after I taught this lesson where one of my students had a case of ACE inhibitor-induced angioedema, and fortunately, they caught it immediately. Uh, so I was pretty proud of them. It's amazing how that works, though. You teach something, and then the students are confronted with it very quickly after. So this is another scenario that we wrote. I wrote this for me to be the patient. And the thing I wanted to teach with this one is that AFib can happen in a lot of different circumstances when people are ill. And so I wanted to make sure that the students, number one, recognized that the patient was in AFib, but also they made the decision that the AFib wasn't the problem at that moment. So you got a situation where there's hyperglycemia, there's dehydration. Um, Treating the AFib is not the first priority in this patient. Rehydrating them is, and then next trying to handle the sugar at the hospital. But EKGs in particular, I found are a really big confounder for students. And so in our program, we focus on making sure they ask the question, is the rhythm the problem here, or is something else the problem, and that's what's causing the rhythm? But we ask that question all the time because I want them to be thinking about this. I want them to be interpreting this. And that's one of the things you got to decide when you're confronted with an EKG rhythm is this something I need to do something about, or is this extra information that's not really helping me treat the core problem? Because they default to wanting to treat the EKG immediately. And they also default to wanting to do the maximal amount of things for that EKG. So, like in this particular case, I've had students want to cardiovert me because my blood pressure was low and I was in AFib when there was a much better explanation for why my blood pressure was low. And so, even if they don't do it correctly, that still leads to a great conversation afterwards about what they missed and how to interpret all that. Some other sources of finding diagnostic challenges that you can incorporate into your curriculum: FOAM, free online access to medical education, so blogs, podcasts. The reason I love blogs and podcasts is because they're a great place to start learning about something. You always want to verify what you're told with more robust literature, but I love listening to experts talk about how they handle problems. So you get two people or three people or whatever number is on a podcast talking about how they manage certain kinds of patients. There's a lot of value there. And so I would never use anything without verifying it, but it's a great place to start. Case reports, if you look in the literature, the medical literature, there's all kinds of case reports you can use, journal articles, non EMS textbooks. In medicine in particular, there's lots of textbooks focused on diagnosis and diagnostic challenges. So you can use some of those and adapt the cases that they have for physicians to our situation. There's nothing better than real calls, calls that you ran or that other people have ran, your students have ran. Turn those into content or scenarios or assessments. Talk to your medical director. They're going to be a good source of information on this. And then other paramedics. So broaden your reach, look for other sources, take the time to verify that they're going to teach what you want, make sure you craft them for your students, and then incorporate them in your curriculum. Another thing I like to do is I like to have students create scenarios. I think this is important if for no other reason than we know from Bloom's taxonomy. This is actually the revised taxonomy. I want to be very clear about that. The original was a little bit different. The height of complexity, according to Bloom, in the revised taxonomy is to create. And so I wouldn't want a student to create a scenario from at the very beginning of the program, unless it was an EMT level scenario. I've done that. But towards the end of teaching them a certain block of instruction, like trauma or cardiology or whatever, have them write some scenarios that then they take their classmates through. And so everybody writes a scenario for this lab session, and then we run through all the scenarios, taking turns. But the act of creation means they've got to put things together. They've got to make judgments about how the patient would respond, what assessment findings would be there, how they would present, all of these things. And the students that we've done this with, it's really helped them understand how a particular disease process is going to work. And one of the things we added to this that I think has been very helpful is we have a scoring guide at the end of the scenarios that they write. And that scoring guide is based on the National Registry scoring sheets, either for the oral station or the out of hospital scenario. Practical station for us is a out of hospital scenario. Verbal scenario for us is an oral station. But we use that grading tool to grade them towards the end because we were preparing them for the practical. We're going to have to rethink this a little now. But I wanted them to make decisions about how they would grade them using that grading tool. So I created this rubric that they can fill in to make decisions about what's important in this particular situation. And so it's not just acts of omission, it's also acts of commission, whether it's in whatever category. So leadership and scene management, patient assessment. I love trying to find things in patient assessment. So if you have a stroke patient or some other altered mental status situation, not assessing blood glucose would be a problem. So we would want to take off for that. I also want them to make judgments about whether something is required versus something is good to do, but not necessarily required. So if I was writing a scenario that involved anaphylaxis, IM epinephrine would be the entry level, the number two, the mandatory action. And then solumedrol and Benadryl and other things could be in number three. So this is extra. This is good things to do, but it's not the mandatory, the minimum. And I find personally that those discussions are very helpful too with the students about, okay, well, what's the absolute requirement? What needs to happen? What's nice to happen? Because I find in particular with anaphylaxis, they want to give the Benadryl every single time, but you really got to push them to give the epi. And so they're almost afraid of giving the epi. And so we need to have scenarios that push them to make that decision. And then if they can't do that, we need to talk about why. Or, if the fact they finally realize, hey, this is what I should do, they'll remember that the next time they're confronted with all of this. So I think that these are all important areas. I like this grading tool actually from the registry test, and having the students create this rubric, I think really helps them when they're grading the scenarios, but it helps them just to process the information. And that is all I had. I realized I finished a bit early. I think I was a little nervous and talking too fast. But is there any questions or any comments that people want to make? I'd love to hear what you think about this, or what could I do better? What have you done that works really well? Let's help each other out. I swear I'm going to add a sound effect of crickets when I do this the next time. Okay, Catherine asked me what my pass rates look like using these models. Well, we only been working on this for about a year, so I really haven't. I had one cohort that's tested, and my pass rate's about the same. Uh, Looking long term, I'm looking to see more of an improvement. But I will say that we have been in my program. We've been talking about clinical judgment for probably about 10 years. So some of what I'm talking about and some of this is not new recently. Some of these techniques are new, and I've just anecdotally I've found that the students seem to get more out of them, but my pass rates haven't changed a whole lot yet. I'm looking for that to improve. But that's a great question. And part of our problem is just we only do one cohort a year. So making a change and then evaluating whether that change has had a benefit or not sometimes is tough because I just don't have the numbers. I'm kind of jealous of you guys that do three or four cohorts at a time and have lots of students. The information that generates must be amazing. The pass rate on the NREMT has been about the same. Uh, Competent level practitioners, I say we're getting better feedback. I'm getting a lot of feedback from the employers of my graduates that they're happy with where the students are getting to. And I tell you the thing that's the most gratifying to me though is I've had a lot of students, especially in the last couple of years, come back to me and talk about calls that they've had. And like just the other day, one of them was calling me about a call they had where the person's heart rate was 180, and the two paramedics that were working with them they were cued in on SVT. That's all they could think about. And he told me, he said, look, all I could hear was in your brain, I mean, in my brain saying, is the rhythm the problem or is the problem the rhythm causing the rhythm? And so that in this case, it wasn't SVT, it was something else entirely. They just happened to have a heart rate of 180. And because of the way we had taught that, they had a much better grasp of what was going on than some of the people they were working with. And so I think, little areas like this where as in general, we may not have done a good job teaching our students how things actually work. that really helps. And so one of my focuses has always been narrow complex tachycardia because I didn't understand it earlier. So I try to teach it better. And so yeah, I think that the most positive feedback I've gotten has been from the graduates themselves coming back and telling me ways that what we've been doing have helped them. My partner who teaches OB, she's got a lesson on preeclampsia, and she makes sure to understand that a person can get preeclampsia even after they've delivered the baby. And so because they know that, we've had several students catch postpartum preeclampsia after they graduate because they knew that was a thing and they'd run a scenario where they'd encountered that. And so I can absolutely say that developing these patterns in the program does lead to people recognizing things in the field. So, but as far as numbers, I don't have great numbers yet. I need that. You're absolutely right. I just don't have them yet. Stay tuned. Have you found students' right scenario really does help them with real DX they're struggling with? Yeah, thank you. I think it does. It's not busy work. How can I connect, collaborate with you? Well, I have my business card right here. Please send me an email. Okay, there we go. Also, if you are not part of the paramedic faculty Google group and you would like to join, just send me an email. Any email technically could work. If you have Gmail, that works better. But the group is a great place to get feedback and to get help, and we'd love to have you. Any other questions or any other comments? Again, y'all are as much of an expert at this as I am. I'd love to hear what you think about this. There with you go with the crickets again. Well, all right. Like I said, feel free to reach out to me. I love connecting with my peers, and like I said, I hope we can help each other out. And I really appreciate your time and your attention. And there are two more clinical judgment workshops coming up, one at NEMC in August and then one in Denver in September.